I'm really super happy to be here with all of you. Today I'm gonna be talking about a way of building consensus and showing or providing expert recommendations for different monogenic and rare disorders. Just to start, I do not have any disclosures. And of course, as everybody I think in this room knows, COL4A1 and COL4A2-related disorders have show various syndromes and symptoms in different patients. It's a very heterogeneous disorder. Of course, we already know different manifestations as small cerebral vessel disease, porencephaly, retinal arterial tortuosity, different cardiac, hematological, renal, and musculoskeletal findings. And so for us to achieve some methods and guidelines and management recommendations, we employed the Delphi method consensus that is a very structured and useful tool that has different key features and steps which provide anonymity for an expert of panels in different specialties on these disorders, provide iterative rounds that provide different feedback mechanism and quantitative analysis of the data. It has a wide array of applications. As you can see here, it was applied in different fields: healthcare, public policy, education, business, and scientific research. And you can see two of the studies from 2018, diagnosis and management of Duchenne muscle dystrophy and classification of genetic disorders in Alport syndrome. So with this, I wanted to emphasize that it's widely used in rare disorders before a natural history is inside. We have data for it. We can use such a method to provide some clearance for the medical providers. Of course, as any other tool method, it has strengths and limitations. Some of the strengths, it encourages collaboration with different geographically dispersed providers, as we see here in this room. So coming together and figuring out guidelines together, at least as primary steps, is a strength of this method. Of course, it has limitations. The same strength can be the limitation of this method because there is a bias in experts that are chosen for this type of methodology. But I think different iterations of the same guidelines are helpful. So this method or this first round of consensus will need to follow with more rounds as different clinical guidelines management are developing. So this, of course, will not be possible without our international collaborators and our amazing Associazione and Simona and Francesca, because they brought us all here together last year. And that our consensus development started last year at the round table of the first international conference. We had 31 participants from a wide array and multiple specialties. After that round table, we developed the manuscript and worked in multiple rounds and iteration and edits of the manuscript. After that, we provided an online anonymized surveys for our experts and specialists, and the agreement threshold for this consensus was 70%. And then I will show some of the results, but I wanted to say that all of the recommendations reached the agreed threshold for the consensus, and some of them I will show here by system. So in the neurologic and cerebrovascular system, we reached agreement on providing neuroimaging screening with established stroke protocol and vessel imaging, provide extra caution and advise extra caution when any endovascular procedures are needed in this population of patient, avoid high-intensity prolonged physical activities, and in cases of fetal intracranial hemorrhages of unknown cause that are identified on ultrasound or fetal ultrasound, provide or evaluate further with fetal MRI. Of course, when intracranial aneurysms are present, to consider screening all the other vasculature like chest, abdomen, pelvis, provide anticipatory guidance regarding potential epileptic seizures, as we heard this morning, and then prevent elevated blood pressure and, of course, provide strict peri-procedural blood pressure support. In terms of neuro-ophthalmological evaluation, to provide evaluation of visual function, baseline screening ophthalmological examination, and assessment for retinal vessel tortuosity and hemorrhages, and of course counsel for regarding transient visual loss, which can usually warrant an urgent ophthalmology evaluation. In terms of cardiac and hematological systems, we reached conclusion for a baseline electrocardiogram and echocardiogram in this patient population. In adolescents and young adults, to consider stress tests, and of course in patients with history of syncope or palpitation, to consider long duration portable cardiac monitors. We do not have yet good data in this, or good to none data in this specific patient population on risk and benefits of antiplatelet and anticoagulation treatment. So every case, every patient should be discussed case by case with a multidisciplinary team. And of course, that is the most important cause is an ischemic stroke. So in the absence of previous intracranial hemorrhage or in presence of a strong indication, these types of treatments can be advised. And some occasional use of NSAIDs had been reported and tolerated in this patient population. On the renal and musculoskeletal system, of course, a baseline kidney and bladder ultrasound, urinalysis is recommended. In cases of albuminuria, it is advised to assess and quantitatively evaluate the patients, and in terms of proteinuria in patients, to refer the patient to a nephrologist and consider RAS blockade or inhibition. Of course, baseline measurement of CK and monitor for different muscle pain, cramps, skeletal muscle involvement that are not widely, but in HANAC phenotype of this disease is widely known to be present. And then at the end, we reached a consensus in these genetic recommendations, a consultation with genetic counselor and geneticist, and if there exists suspected fetal diagnosis, to consider consultation with a fetal and neonatal neurologist if available by country, by center, of course. Delivery at a tertiary care center may be considered, and the high-risk pregnancy obstetric follow-up is highly recommended, but again, advisable case by case. A cesarean section delivery may be considered in case-by-case basis in a mother of a fetus known with a pathogenic COL4A1 or COL4A2 variant. I wanted to point out, I'm not so sure if the pointer works, but basically at the end you can see that this manuscript is submitted to the journal Genetics and Medicine at the last round of reviews, so we are very hopeful that in the coming weeks we will have a publication that we will be able to share with everyone. In terms of future research and directions, we really hope that the whole entire field of researchers and clinicians would explore father genotype-phenotype relationships, and we will know about long-term outcomes in affected individuals. Of course, developing of testing and developing novel therapeutic agents is important for this patient population, and expanding patient register to enhance data collection and participation. Talking about participation, we have a study based at Massachusetts General Hospital. We have a natural history study that is called Young Genetic Stroke Alliance, that we have enrolled multiple patients from all over the world. They are more self-reported, meaning we do not work with hospitals directly, but patients enroll themselves in our study. They provide us our medical records. Everything is de-anonymized. We have around 20 COL4A, COL4A2 patients in this this study known, and clinically we follow more of these patients, and they are and other monogenic disorders. So if anyone would like to enroll here, that is my email address, and the QR code is my email as well. You can find me, reach me for any information that you would need on this. We think that different studies as that are PI initiated are important until we have really robust registries and natural history studies that are available across the globe. And as an addition to my study, to my presentation and the initial study, I was asked to talk about some preliminary data that we presented first at the webinar for North American Gold Foundation and last week at International Stroke Conference. So we, as a research lab, were interested to look into different biomarkers, both in cells, serum that we have biopsy, cell lines, and imaging from these patients. So we wanted to identify a neuroimaging biomarker that can help us understand more about this disease or work as a target or like a target for a gene therapy in the future. So in addition to just evaluating the patients with traditional MRI methods, we employed some specific DSC-MR perfusion, which is dynamic susceptibility contrast MRI perfusion, and we investigated the microvascular dysfunction in these patients. So there are two ways to look into that: a traditional method, which is standard value decomposition, but sometimes it can underestimate the cerebral blood flow, and our approach is a Bayesian estimation of cerebral perfusion that allows and creates a vascular model or map for a more accurate estimation of vascular pathology. These types of biomarkers were evaluated, published in other monogenic disorders. Here you have an example of ABCD1 related changes in microvascular perfusion in ALD subjects. So you can see that you have controls and patients with ALD, and all of the biomarkers that I will touch upon in the next slides were evaluated in white matter and gray matter as well. And on the far right, you have pre and post hematopoietic cell stem transplant in patient with CALD, which is the fatal version of ALD in boys. And after treatment, the microvascular perfusion abnormalities improved in these patients. This is a paper from 2021. There is another paper from Nature 2023. All this work is led by Arne Lauer. He's a neuroradiologist from Heidelberg University and a researcher with our lab, that he leads our work in microvascular perfusion in different monogenic disorders. So I would advise you to check his work out. And in our patients here, you can see representative FLAIR images of control and COL4A patients and DSC-MR perfusion maps. So we have here the neuroimaging biomarkers that I was talking about, which one of them is K-up, which is contrast leakage constant. This neurobiomarker speaks more to the blood-brain barrier integrity and leakage, and CTH, which is capillary transit time heterogeneity, that is representative of the uniformity of microvascular blood flow. And you can see here classic FLAIR images that demonstrate phenotypical extensive white matter hyperintensities in COL4A patient, and as well in the deep gray matter, some hyperintensities within the caudate heads. Further, we evaluated and compared these biomarkers between COL4A patients and controls, and we demonstrated a significantly elevated K-up in the segmented brain tissues, tested including gray matter, white matter, and normal appearing white matter, and COL4A patients also significantly displayed reduced CTH in gray matter. While there was no significantly statistic difference in CTH between control and patients with normal appearing white matter, we believe we might have more robust results, of course, when we have more patients. This study or preliminary data is on 5 scans from 4 patients. Further, we evaluated we showed elevated flow heterogeneity, higher oxygen extraction capacity, and reduced upper limit of the metabolic rate of oxygen in these patients in normal appearing white matter. All of these biomarkers speak on like the capacity, the leakage of the capacity of the microvascular flow, the disruption of the microvascular flow, and blood-brain barrier leakage in this patient. So we believe these, like the DSCMR perfusion can be a tool to evaluate this patient and then to evaluate potential treatment success in the future. And these are the references and methodologies that went into my presentation. Thank you very much.